Hello and welcome. I'm Professor Adam Thompson, and in this video we're going to talk about Sgarbossa's criteria, or the Sgarbossa criteria, for interpreting STEMI, or the presence of an ST-elevated myocardial infarction, while there's a pre-existing left bundle branch block or a ventricular pacer. Now typically when you look at somebody that's got a bundle branch block, you'll identify it by noticing that the rhythm is supraventricular. In this case, it looks like we have a sinus rhythm. And then you'll say it's wide, right? So you have a QRS complex that's wider than 120 milliseconds or 0.12 seconds. Once you identify that you have a wide QRS complex and you know that the rhythm is supraventricular, you look at V1 and you say, all right, well, it's mostly negative. The terminal wave is certainly negative. Which is down, right? And if you push down on a turn signal while you're driving a car, you're turning to the left. So a lot of people like to use that turn signal method to remember your bundle branch blocks. And that's the first step in identifying that's a left bundle branch block. The next step is to look at leads 1 and V6, and you should have a monophasic, meaning it's almost all in one direction, R wave. It's all positive, right? Which is true in leads 1 and V6 on this 12 lead we're looking at. It's again negative in V1, it's wide, it's supraventricular, so we have a left bundle branch block pattern. Now, in the past, we used to say if you have a left bundle branch block pattern, then you don't interpret any further because it's impossible to identify ST elevation indicating a myocardial infarction when there's a left bundle branch block present. There was some caveat to that, like if you knew it was a left bundle branch block, you would say that that's equivalent to it being a STEMI, and you would activate the cath lab based on that. However, Dr. Elena Sgarbossa, she's an Argentinian-born American cardiologist. She developed and validated that clinical prediction rule that we call the Sgarbossa Criteria. And what that is a set of rules based on concordant and discordant ST segment elevation. What does that mean? What is concordant and discordant? Well, discordant ST segment elevation is ST segment elevation that's in the opposite direction as the terminal wave, where concordant ST segment elevation is ST segment elevation that's in the same direction as the terminal wave of the QRS. And if you don't know what I'm talking about, I'm going to explain that in a second. So normally, Dr. Sgarbossa identified that in patients with left bundle branch block or a ventricular paced rhythm, the infarct diagnosis based on the ECG it's very difficult. And she noticed that the norms for this patient is much like this one that we were looking at. There could be some ST segment elevation on this 12 lead that is normal, that is not indicative of an MI. In fact, you'll have more ST segment elevation on a left bundle branch block 12 lead than on your typical 12 lead without an intraventricular conduction delay. And that could look like an MI when in fact there isn't one present. So we call that an STE mimic typically. So Dr. Sgarbossa developed this criteria. There's three very specific criteria. The first one is concordant ST elevation of at least 1 millimeter in leads that have a positive QRS complex. All right, concordant ST elevation of 1 millimeter in leads that have a positive QRS complex. If you have that, it's a score of 5. So this is a scoring model. Concordant ST segment depression greater than 1 millimeter in leads V1 through V3. So we have concordant elevation in the leads that have a positive QRS. Concordant ST depression in V1 through V3. Typically, those leads have a negative QRS with a left bundle branch block. And then finally, what we would call excessively discordant ST segment elevation, which would be greater than 5 millimeters based on this criteria in leads with a negative QRS complex. And that only gives you a score of 2. So what you do is you add your score together, and what you identify as that's final tally will indicate how sensitive or specific that 12 lead is for the presence of a STEMI or an MI. These criteria are specific, but they're not super sensitive for myocardial infarction when you talk about the original Sgarbossa criteria. A total score of greater than or equal to 3 is reported to have a specificity of 90% for diagnosing an MI, meaning that it's a likelihood, 90%, that you actually have a myocardial infarction. However, there are many MIs that will go unnoticed because it's not that sensitive of a criteria. So I said I would mention what a concordant and discordant ST segment elevation is. So here on the left, this is what we call concordant ST segment elevation. You'll notice that the dominant wave is the terminal wave here. It's positive with this QRS complex, and the ST segment is elevated. It's up. So when they're both in the same direction, the terminal wave of the QRS, which is the last wave of the QRS complex, is up, and so is the ST segment. That's concordant elevation, and typically that's worse. All right, when you see concordant elevation, that's almost always a bad sign. Discordant ST segment elevation is in the opposite direction, where you have a QRS complex with a terminal wave that's negative or down, and the ST segment is up. Okay, so that would be opposite. That's discordant ST segment elevation, and that can be bad. However, with all of your ST mimics, or most of your ST mimics, you have this discordant ST segment elevation. Early repolarization. A lot of normal variant ST segment elevation that you see in leads V2 and V3 on a standard, normal sinus 12 lead with somebody without any complaints might have up to 1 millimeter of elevation in those leads because of the T-wave discordance. What happens is this ST segment gets dragged up in the opposite direction. You could also have the same thing with ST segment depression. Okay, so you can have concordant ST segment depression where the terminal wave is negative and the ST segment is also negative or depressed, right? They're both in the down direction. And you can have discordant ST segment depression where the terminal wave is positive, but the ST segment is depressed. It's negative, right? So they're in the opposite direction. So concordant just simply means it's in the same direction, where discordant is in the opposite direction. So using Sgarbossa's criteria, we know if we have that concordant ST segment elevation where we have a positive QRS complex, right? You have greater than 1 millimeter, that gives you 5 points on the criteria. And if you have discordant ST segment elevation greater than 5 millimeters, that gives you 2 points based on that Sgarbossa criteria that we looked at here. Remember this? All right, so concordant ST segment elevation greater than 1 millimeter and leads with a positive QRS, 5 points. You get 2 points for this excessively discordant greater than 5 millimeter elevation. All right. We also have that rule of ST segment depression and leads V1, V2, V3, where you have concordant depression, meaning you have a negative QRS complex and the ST segment is depressed. That also would give you 3 points. All right. So if you had this along with the excessive discordance, of course, that would be enough to say that there's a high likelihood that you have a STEMI. So let's look at a 12 lead here and let's apply this Sgarbossa's criteria. So we can ignore the rhythm for what we're doing. We're just identifying ST segment changes. We notice that we have a left bundle branch block pattern. All right, so we want to apply this rule. We do have a supraventricular rhythm, and we want to look for concordant changes and discordant changes. So what we see in these inferior leads is a concordant ST segment depression. Now this isn't V1, V2, V3, so we're not going to apply the rule here. However, I will tell you that is, a sign of a reciprocal change. And the leads that it would be reciprocal to would be these high lateral leads. So let's look at those. And we do in fact see some concordant ST segment elevation in AVL. All right, hopefully you can see that. Maybe I can zoom in on it a little bit. All right, go ahead and take a look at AVL, and you'll notice that this isoelectric line is right about there, the middle of the arrow there, and you could see about 2 millimeters, maybe even 1.5, because the isoelectric line is a little bit above this millimeter of ST segment elevation. Okay, let's move this 12 lead back. All right, so looking further at this 12 lead, up at lead 1, you also see a little bit of ST segment elevation. Now that would be discordant because the terminal wave is in fact negative, so you don't have excessive discordant elevation there. So we'll move on over here to V1, V2, and V3. Now you don't have a terminal R wave, so the concordant elevation isn't at play here. However, we have excessive discordance. All right, let's see if I can zoom in again, once again here on these V1, V2, and V3. All right, so if you look, remember you're looking for at least 5 millimeters of ST segment elevation. Remember, every small box is 1 millimeter, so you have 1, 2, 3, 4, 5, maybe 6 millimeters of ST segment elevation. So you get 2 points for that. 2 points based on that rule, along with the concordant elevation. We've already reached plenty of points indicating we have a myocardial infarction. In fact, if you continue on over here to V5, you can see concordant ST segment elevation, albeit not that impressive of a QRS complex. Look how much elevation there is in relation to the size of that QRS complex. Very small QRS complex with about 2 millimeters of ST segment elevation. That's pretty significant, especially that is concordant ST segment elevation. All right, let me zoom back out. Here's another 12 lead. Now this 12 lead is showing you a paced rhythm, all right? And I should kind of state where I get some of these 12 leads from. This first one that I was showing you was one that I've acquired. This one showed up on Dr. Smith's ECG blog. So this is a paced rhythm, all right? And you can use the Sgarbossa criteria to identify the presence of an MI with a ventricular paced rhythm. And the ventricular paced rhythm is going to have the spikes right before the QRS complex. Of course, the spikes aren't that, you could see some small ones here in V3. They're not that impressive because it's a newer pacemaker. So the monitor has gone and identified where those spikes would be with these arrows. So again, let's look for concordant and discordant changes. You should be able to see in leads 1 and AVL, just like the last 12 lead we were looking at, you do have some concordant elevation. All right, you have some concordant elevation in 1 AVL. Those are both leads where you have a terminal R wave, so it's positive with elevation. And over here in V1, V2, we don't have a left bundle branch block pattern, but again, it's a ventricular pacer, so we're still using the same rules. We may see here in V3 about 5 millimeters of elevation. Remember, that gives you, maybe it's just under 5 millimeters, so let's not even count that one. Let's just go with the concordant changes. Over here in V5 and in V6, you do see concordant ST segment elevation over here, which again is that gives you 5 points when you have concordant elevation, utilizing the original Sgarbossa tool. So that would be a ventricular paced rhythm in the presence of an MI, or an MI in the presence of a ventricular paced rhythm. Here's another left bundle branch block. This one's from ecgmedicaltraining.com. Great website. And on this 12 lead, I'm kind of using this one as an example of why the original Sgarbossa tool is not that great. Because look how big these QRS complexes are. Look how deep they are. What happens with a left bundle branch block is the deeper the QRS complex, the more elevation you will have as a normal variant. So even though utilizing the original rule, we may get more than 5 millimeters of ST segment elevation here, unfortunately, it's not highly indicative of it being a true MI because this QRS complex is so big. All right. So because of that, Dr. Stephen Smith of Dr. Smith's ECG blog developed a modified Sgarbossa criteria, which is really great. He uses the original Sgarbossa criteria for concordant changes. So if you have concordant ST segment elevation in any lead, or concordant ST segment depression in V1 through V3, those are both signs, as he's recognized, of it being an MI in the presence of a left bundle or a ventricular pacer. However, when it comes to discordance, he uses that same term, excessively discordant ST segment elevation. However, his rule is a little bit easier. You don't have to remember the 5 millimeters. It's 25% or greater of the preceding S wave amplitude. Maybe that's not easier for some people because now you have to do a little bit of math. But if you have a certain amount of ST segment elevation, let's say you have 5 millimeters of ST segment elevation, just like we were talking about before, but the QRS is 30 millimeters. Well, that's not, 5 millimeters would not be a quarter of 30 millimeters, right? So it's not highly indicative of an MI. That would not be excessively discordant. That would be a normal discordance. So his rule, all right, is you take the amount of ST segment elevation. So looking here, we have 5 millimeters. You compare that to the size or the depth of this S wave, which let's say we have a 9 millimeter S wave here. And if the 5 millimeters or the amount of ST segment elevation is at least 25% the size of that S wave or the depth of that S wave, then you have a high likelihood of it being an MI. So in that case, you're more than 50%, right? So obviously that would have a high likelihood of being a myocardial infarction. And again, he still keeps the rules of concordant ST elevation and concordant ST depression. So this is that first 12 lead again. All right, I'm actually going to make this a little bit bigger. All right, let's make it bigger. And just looking at it again, now if you look at V1, V2, V3, let's just concentrate on that discordant elevation we were talking about. If you look at how much elevation you have here, I think we said we had 6 millimeters. Let's just go with 5 because that baseline is a little bit above there. So let's say we have 5 millimeters of ST segment elevation. And the depth of this S wave, all right, go from the isoelectric line down, is about 11 millimeters, all right? So is 5 millimeters at least 25% of 11 millimeters? Sure, it's 25% of 20, so it's definitely more than that when it comes to 11 millimeters. So that's highly indicative based on Dr. Smith's modified Sgarbossa criteria. And I like that he kept the name Sgarbossa criteria, giving Dr. Elena Sgarbossa the credit for originally coming up with, the actual criteria. Now, if you look at V4 on the same 12 lead, we're not switching gears, we're staying on the same 12 lead. If you look at how much elevation you have here, let's say we have, based on this isoelectric line, maybe 3 millimeters, maybe 2.5. All right, and then the depth of this S wave, all right, is only about 4 or 5 millimeters. So you still have at least 25% of of the depth of that preceding S wave, ST segment elevation, even though you don't have 5 millimeters like the original Sgarbossa criteria required. So if you only had this V4 to measure to base, your Sgarbossa criteria on, you would meet it based on the modified Sgarbossa criteria. So there's one instance where you would have identified, the presence of an MI with a left bundle branch block, utilizing the new criteria that the old criteria might not have caught, that single lead there. And that's pretty much what Sgarbossa criteria is. It's just identifying the excessive discordance and concordant ST segment changes. Here's another ventricular paced rhythm. This one's from Dr. Smith's ECG blog. And I think this one's more obvious when you're identifying it. Of course, you're going to look for your concordant and your discordant changes. Now look at the excessive discordant in these inferior leads. The excessive discordant ST segment elevation you have, it's almost the size of the S wave, right? So you have a significant amount of elevation there. You don't have a whole lot of elevation over here in V1, V2, V3, which could be a sign that the ST segment is actually going to be depressed, because when you have inferior changes, you can expect posterior changes as well, and that would show up as depression. So this ST segment may, as a normal variant, have been slightly elevated, but now it's starting to come down. Okay. Over here in V5, you could see some concordant ST segment elevation. That's a little R wave at the end there. And the ST segment is elevated, so that's always bad, right? So this is a myocardial infarction in the presence of a ventricular pacer, which otherwise, if you didn't know about Sgarbossa criteria, you wouldn't even know to look for, all right? So this patient can get expedited care, which is what it's all about, getting them reperfused early on. Remember, time is tissue, and utilizing this Sgarbossa criteria can really make a difference for those patients that have a left bundle branch block or a intrinsic or internal pacemaker.